I mean, that trial was actually kind of a surprise hit for me. DB09 came at a very interesting time because we also had the results from PATINA that I think we are all very, very excited about, where patients who were already responding to their Cleopatra-style regimen, after they finished that induction period and they were hormone receptor positive, were then randomized to get palbociclib with endocrine therapy plus their HER2-targeted agents versus the HER2-targeted agents and endocrine therapy alone. And I mean, that trial was actually kind of a surprise hit for me. I mean, I expected that we would see benefit because I think we've known that CDK4/6 inhibitors in HER2-positive disease have had activity for a while, but I guess I didn't expect the magnitude to do so well. And not only did we see the control arm performing very, very well, but then the patients who got palbociclib had really an impressive improvement in their progression-free survival. And I think we're all very comfortable with palbociclib. We've kind of been looking for a new home for it. Yep. And so when you see that amount of activity with a drug that you're very comfortable with, it leaves you to say, okay, you know, this is something I would be very comfortable incorporating. But again, we don't have a clear maintenance phase for if we're trying to incorporate DB09 with PATINA. It's a little bit hard to know how to do that. I think we're all finding our way. We're all talking about, you know, is there the opportunity to have an induction phase with TDXD plus pertuzumab? We're not there quite yet. There's going to be some data that will lead us there with the Demether study, I hope. But we have some good maintenance data that we should think about with PATINA. And then at this meeting, we saw the data from HER2CLIMB-05, which is looking at use of tucatinib in that very similar maintenance setting. And here we're looking at hormone receptor positive and hormone receptor negative patients. And we saw a benefit in both subgroups. I think more compelling in the hormone receptor negative population, perhaps. But certainly now we've got two agents with different mechanisms of action that we might want to use in this population. So a lot of data all at one time. And I think this is where sort of that clinical gestalt impression is where we're going to make a lot of decisions in the short term of like, what did the patient receive before for therapy? How much is their disease burden now? What's their performance status? How aggressive can we be? And we'll figure it out along the way.
So in your community, broadly speaking, not at the university, but broadly speaking, do you find people are adopting TDXD, not necessarily in this setting, but just more broadly?
Yeah, for sure. I mean, I definitely noticed when the drug first came on the scene that I was seeing a lot of second opinions in people who hadn't gotten it, but I think everyone's becoming a lot more comfortable with it. I think moving it up into the front line, I think we're going to once again see in the community a lot of questions about how to use it and more kind of referrals to the academic centers to tease that out. And then I think it will start to be more widely adopted in the same manner. And I think in my practice, I do think it's going to be difficult because like you said, I think Cleopatra and DB09, a lot of the patients didn't get endocrine therapy at all. Right. So it's hard to know what to do with those patients specifically. I think the DB09 regimen will be easier for me to implement in a HER2 positive, ER negative patient. Yeah. But in the ER positive, for me at least, that induction switching over to a maintenance that includes endocrine therapy feels like a better approach.
Yeah, I mean,
without data.
Yeah, right. I was going to say, you know, if we make the switch, we're really switching away from TDXD.
Yeah.
Particularly if we're thinking about a CD4/6 inhibitor,
Exactly.
because then you have two cytopenia, drugs that can cause hematologic toxicity on board.